Go ahead.
Hi, good afternoon. It's a real pleasure to be with you this afternoon in this Meril live case. And I would first thank the Meril people for giving me this opportunity to in this case. So I'll request Dr. Vivek to briefly introduce the case.
Thank you,
Over
sir.
to Vivek.
A very good afternoon to everybody there. I'll just give you a brief case summary of this patient. This is a 60-year-old gentleman, an active smoker with no history of diabetes or hypertension. He had been operated for a carcinoma thyroid about 10 years back and underwent a radiotherapy for that. He is not cured of that. He presented to us with 7 days history of unstable angina with rest angina uttering for the last 24 hours. He was hemodynamically stable. And this is the ECG of this patient. We can see that there is a biphasic T wave as well as deep inverted T waves with a preserved R wave, indicating a proximal LAD lesion and a preserved myocardium probably. And his echo, this is the second ECG in follow-up. We did a echo screening of this patient, and he had a EF of about 35 to 40%, and troponins were mildly elevated. And so we did an angiography, and Dr. Viveka will further elaborate on the angio shots and the plan of treatment. Thank you.
So this is the patient who had, recurrent angina. In fact, he had to take 20 tablets of sublingual nitrates while he was coming to the hospital. And can we show the yesterday's angiogram? We had done a cath yesterday, and he had almost severely narrowed ostial LAD, and there was significant plaque at the distal left main also, you could see, and then there is a moderate size circumflex. These the guide catheter we have taken just now before we start became live. You could see that is a bang ostial left anterior descending artery. There's a huge artery type 3 LAD, and no wonder he was having severe rest angina. Because of the ischemia, he's showing repeated ventricular ectopics as well. Can you go to the next view, the cranial view? Yeah, so this is the patient minus. The moment we wired, the flow in LAD stopped completely. So we had to, and patients started having angina. So you could imagine how critical this blockage was. And you can see that dye was sticking in the proximal part of the LAD. So next, we have just done a balloon dilatation with 2.5 into 12 millimeter balloon at 10 atmospheres. Next slide.
Did you have pain on the
So you could see this is place where we are.
It was effective because restored flow. Peak heart rate.
So this had restored the flow, but you can see that the LAD was quite big artery, and there is some spasm in the proximal part of the left main. You could see if you compare from the LAD to the left main, there is, left main looks a little spasmodic, and LAD looks almost 3.5 to quarter to 4 millimeter size vessel. While we were waiting to go live, again, next, the flow in the LAD again became little sluggish, so we had to give, intracoronary adenosine and diltiazem and nitroglycerin. And then, can you show the last picture?
Does he get chest pain
Yeah,
with,
so next.
with the slow flow?
Yeah, so after this adenosine, this flow returned to normal. We gave a lot of adenosine and diltiazem, and the flow is, so this is the place where we are now. So again, next we wired the circumflex also, because this is now the position. Can we have a shot again?
So your femoral.
So this is the current position now.
Is it 7 French catheter or 8?
Yeah,
or
femoral 7 French. Yes,
7
yes,
French.
yes.
Extra backup.
No, so this is 7 French femoral catheter.
Okay.
Yeah, extra backup. So this is the position where we are. In fact, we intended to do IVUS, but the moment it connected, it's just not working. Hopefully, as the case progresses, the IVUS would work, and then we can show you the IVUS images as well. But it's, as of now, we are just not able to boot the machine for the IVUS machine. So I would like to know from the panelists that what would be the strategy in dealing with such a huge LAD, which is bang ostial and distal left main also significant disease. You could see carefully the circ ostium also has probably some thrombus has migrated into the circ ostium with the proximal most part you see. So their strategies could be, the bang ostial stenting vis-a-vis coming into the left main and stenting the whole thing together. So I would just like to know the panelists what what would be their approach. Can cranial please?
The last patient I had like this, I pre-dilated quite a bit of the ostium and then implanted a biodegradable stent. I'm not sure if you have a big one. I'm not sure what the size.
But you cannot going up to
Necklace.
you can go up to 4.
So it looks like a 4O, so I think we would use a
can go up to 4.
drug-eluting metallic with,
And I had some
but left main
some
could be
struts
even
hanging into the
4.5.
left main.
So
Yeah.
you put the stent on.
So
on
would you
the,
cover
at
the whole
edge?
left main or you would come?
Okay.
Plus.
Bigger than 4. I mean, you could stent from the left main into the LAD and this.
Yeah, I mean you can pause the late.
So we have given
but
some
I
vasodilators.
wouldn't honestly choose
Yeah.
for a BVS here because in the end you
Yeah.
don't have the issue of
Uh-huh.
the surgery in the future at this level. One issue for me that is nice of
Yeah.
the BVS is the distal lesions because then they disappear and the surgeon can eventually operate there. In the ba-
Everybody has to.
No, but it's because we just start putting the BVS, so we have to wait a couple of years that they
we have to wait
disappear.
5 years.
That they disappear. They're still there. Yeah.
Epicaudal.
But I think the big question.
I have a question from the audience.
Yeah,
Is
sure.
the right okay? We haven't seen. Is there any problem in the right coronary?
Right is normal, yes. So right coronary is normal. Can we show the slides previous?
But I think
Yeah,
the big
don't
question
pity.
here is
Right coronary is normal.
is whether who would go for let's say ostial LAD stenting, trying to stay at the edge of the LAD, or who would go for a left main LAD stenting, covering the ostium of the
Yes,
circ.
yes.
I would personally go for a left main LAD stenting, covering the ostium of the circ.
Yes. So that's what we are planning to do. So can we have a 4 millimeter stent?
Yeah.
480.
423. 424. So this is the Meril stent BioMime Aura 4 into 24 millimeter, cellular coated stent. So what we would do is we will go right from the left main covering the ostial LAD and then, do a pot in the left main.
It is 40 millimeters for all.
4.0, yes.
Or by what length?
By length.
24.
24.
24, okay.
Yeah.
No, it is BioMime.
Yeah, so it's
but
a
it's BioMime,
drug-eluting metallic stent with bioabsorbable polymer. So this is time-tested stent from Meril Life Sciences. We have used more than 3,000 stents of this BioMime Aura stent, and that's very good. Long-term results are also very good and proven. And since it's a left main, I think we would prefer metallic DES rather than because there is no issue of future uses for the stent. The bypass graft site and all those things are not an issue.
And with the 4
So can we have a
millimeter
check shot? Yeah. It has got also the mid segment has got open cells, so probably the side branch access would be much better, though in such a big vessel that's not been an issue.
It would be
come
nice
the
to
cranium?
see. It would be nice to see this angio in left anterior oblique view, just to see if
Yes.
your stent will
Yeah, that's
cover
what
the
we are doing.
ostium of left main.
Yeah, that's right. So LAOV, left anterior cranium.
LAO, not RAO.
No, that's nice.
Yes, yeah.
Yeah, like this, something like this. Yeah.
So it's covering right up to that place, and the distal
A
segment
bit
is reaching
back,
up
it
to
is
the
our suggestion.
diagonal. Bit. Yeah.
It is the
So I think a
suggestion
bit
of the
millimeter we
advisory
will draw.
box.
Yeah, check. Yeah. Okay, so this is the place where we'll deploy the stent. Can we go? Inflation?
He's fast. He's fast away.
So this is a stent which inflates from the center and goes to the peripherally. 12, negative.
The 4 millimeter stent will grow up to
Areocranial.
if you wanted to have her expand the left main stem part.
So at 12, what is the size? Can we have the bar?
Show there.
So
4.15.
So at 16, it would go to 4.4. So we'll withdraw it little bit in the left main and do a slightly higher pressure. Okay, can you go to 16, please? 16 atmosphere. Okay, negative.
I personally think I wouldn't have
Check
put the
shot,
wire
please.
into the circ. I don't know what would the other have done, but I think
Yeah.
that because of the ostium of the circ was so free of disease, now you have the issue of
Yeah,
the
that
jail
was
wire.
clean, but there was some. There was a
It will be
suspicion
easy
of
to
thrombus,
remove
so
this
that is
wire,
why
I
we
think.
put. Yeah.
But I don't
Yeah,
think it's really
absolutely,
needed
yeah.
to put it before. You can just put the stent on one wire
Yeah.
and then put the
Discuss,
second
yeah.
through there.
It looks that it is free of disease. So.
Yeah. So
Now
we'll
it may be
remove
the discussion.
You can
should
see
we
that the
open
side branch is
the
coming
struts
quite
into
easily.
the circumflex or not? You would.
So we'll just have a look.
And
How
what
does
about
it look
the
like
pot
in
only with, for example,
Can short, please?
4.5 and not opening the struts into the circumflex?
I would do both.
You can see the strut looks good.
Because it's a very big circumflex. The struts would be, I mean, if you don't dilate them, it would be significantly smaller.
Dr. Kumar, there is
4.5
the
balloon,
discussion
please.
among the panelists. Would you like to open the strut in direction to circumflex or not? Or just do, for example, only a pot with 4.5 balloon and just leave it as it is? What is your strategy in such case?
So technically, I would say that some amount of opening should be better, so that for future disease we can access this. If suppose, though it looks so clean that it's very unlikely, but I think ideally
you
we should try and
re-engage the
open
circumflex, so I understand you would like to open the struts. Because
Yeah. Yes. But we will do a first pot and then see how it goes.
Do you try to pass to the distal
we
cell
have-
closer to the carina, or just
Yes.
the first that
Yes,
you get
yes.
you go through?
Yeah, so we tried that it should be, yes. So it's always better to have, from the distal cell. So what we are doing is we are taking a 4.5 milliliter balloon for pot. And
4.56.
stent boost. So we can take help of a stent boost also. Just show the, can you zoom on the stent boost? Okay. Go up 8, 10.
So what is the size of this balloon? It is 4.5 or 4.0?
4.5,
4.5. 6.
yeah,
Non-compliant, you assume.
non-compliant. Yeah, 12, 14. So this is 4.5 balloon and we have inflated up to 14, 16 atmospheres. We'll take the help of a stent boost to dilate the proximal most segments as well. The stent boost, please. Yeah. So proximal most struts would also be dilated. Go up 10, 12, 14, 16.
You want to check in IVUS the results of your stenting?
Yeah, so that's what our plan was, but IVUS is yet not getting booted. So we have connection with IVUS, but after the first shot, the IVUS has stopped working right now. So we are just hoping that by the end of the case, probably IVUS would start functioning. We'll take a shoot now and see. So there is some significant, pinching of the circumflex ostium. So I think we should do a kissing balloon with dilate the strut of the circumflex also. Can you show the cranial? Yeah. So this clearly shows that the ostium of the left main is very well covered, and the stent is nicely positioned, ending just before the diagonal. Can I have a balloon of 2.5 for the side branch?
Could you imagine the spider view also to see if the ostium of the circumflex
Give the spider view, please. So this is the spider view. So some plaque shift is there definitely.
I think that there is just the stent strut which imitates the plaque shift. It is not the plaque shift, it is the stent struts.
Some people would do FFR in this and then decide to treat according to FFR also.
Just the stent strut crossing the circumflex ostium.
The study was published a few months ago. You have less than 20% of positive FFR with this kind of image.
Yeah, so I think technically FFRs would be negative in this case.
We are not treating the vessel.
My idea to recross and treat the ostium of the circ is not for the angiographic result, but it's more to know for myself for the future that I know that I can cross, Because sometimes I had a case where it's difficult
because
to
in
get the balloon
future
down and stuff like that, and that is nice to know right away for me. It's personal.
2.5.
But would you take the underside balloon only to open, not to dilate anything, just only open?
I was just like a 2.5 short balloon, just to put it inside the ostium of the
2.5
circ,
balloon, yes.
just to be sure that I can pass for the future. That's my only idea, but it's not too
So that's what I feel that.
I think we are working with very large stents. This stent inflated to 4.5 millimeter. The cells are very well open, even if you don't. And so we don't need to use a small balloon. If you want to open the cell, you have to use a standard balloon, 3.5. Don't use a small balloon.
Yeah, but if you use a standard balloon,
you have to do a kissing.
you deformate the strut, you have to do a kissing, and after kissing the pot.
What we are doing now is the strategy is to, when you want to open the secondary branch, we are finishing with a pot. In some circumstances, we are not doing a kissing. You can see with this clear stent or stent enhancement system, you can see clearly if you have a deformation of the main stent.
So what is the size of your balloon, Dr. Kumar? What is the size of your balloon, the diameter?
2.5, 2.5.
It's 2.5, okay, thank you.
Yeah, 2.5. Can we go up? 8. So you can see the stent boost also. 8, 10. Negative. So we'll take another picture in spider view and then finish by doing a dilatation of the main branch again. So it doesn't look too different from previous, but definitely there is some space whereby the future intervention can be done. I think there isn't enough data now to treat these with drug balloons. Do you have any experience of that? Anybody in the panel?
Can you repeat, please?
He wants to use
I was saying that
drug-eluting
if we have
balloon, I
data-
understand, for circumflex ostium.
Drug
but,
balloon, yes, yes.
I will not do it.
I wouldn't use
No, I don't want to use it, but I just wanted to know anybody's experience on that.
I
Yes.
ran with colleagues a
0.5.
randomized trial, not in left main, but in many
4.5.
occasions. But it was with the DR drug-eluting balloon, and the results were not really
Yeah,
amazing.
yeah,
We
yeah.
published the study in catheterization
Yeah,
cardiovascular
yeah, yeah.
intervention a couple of years ago.
Yes,
The
yes,
DR
yes.
is also the less
So that's what I
performing
think-
of the drug-eluting balloon on the market. So I think one reason was the balloon itself.
We have published in January this year a study with a drug-eluting balloon systematically inflated in the secondary branch with angiographic control, an excellent angiographic control at 6 months. So we do believe, I do believe that it may have
Yeah,
some
yeah.
space with this drug-eluting balloon for bifurcation, and specifically after BVS need.
Which balloon was that? Which
It
one?
was a French invasive balloon, but it was
Okay.
the equivalent to the Biotronic.
ठीक लग रहा है?
Yeah.
drug-eluting
4.5.
So it's a very well controlled and developed balloon.
But still there is not enough, convincing, powerful data in support of that. So since we have distorted the strut while going into the circumflex ostium, we would finish by redilating with low pressure with the 4.5 balloon of the left main. So this is again the same balloon, 4.5. Can come to Aryo. Aryo. Go up. So 10, 12. Negative. Hmm. 12, 14. Negative. So how many people would have just opted for simply LED ostial stenting? Or everybody would have done the same way as we have done?
I think we would all have done this without it.
You've got a lovely result. It's very nice.
It's really excellent result.
So this is the end result for you. It looks okay.
Very nice.
Yeah.
I think that
So
it's,
unfortunately the IVOS is not working. We would have someone.
you choose a 4mm stent for the distal left main and proximal LAD, and it was absolutely right, because when you look at the result, most of the physician undersize a little bit, the stent, and it is very important to get this quality of results, to use the proper sizing of the stent, and this is a proper size for even for the LAD, proximal LAD.
So what we do is that we don't deploy the oversized stent at a very high pressure, and the proximal part we can do a pot. So that is like a reverse tapering kind of thing. So 4.5 we can make the proximal segment in the left main, and the LED we can keep at 3.5 to 4 millimeters. So we don't go very high pressure. So you can see the LED is also very well dilated. Left main looks beautiful. I wish our IVS was working right now, but it's not yet.
Very nice case, really. And very well done.
Thank you very much. Thank you.
Very nice result.
Thank you once again. So this is all we have from here. And thank you once again to all the panelists and audience. Thank you.
Bye-bye.
Thank you. Bye. Bye. Thanks.